Welcome everyone to today's program. I am Laura Dierda with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. The email will not include the presentation. It is now my pleasure to introduce today's presenter. Dr. Jess Launer is a member of Rothman Institute and Associate Professor of Orthopedic Surgery at Thomas Jefferson University, based in Philadelphia. He belongs to many professional associations, including the American Academy of Orthopedic Surgeons, American Association of Hip and Knee Surgeons, Pennsylvania Orthopedic Society, and has served on the governing boards of the Knee Society and the Philadelphia Orthopedic Society. His areas of expertise include partial and total knee replacement surgery, and is one of the first surgeons in the United States to use and advanced robotic technology for unicompartmental and bicompartmental knee replacement surgery. He is widely regarded as a key innovator in the realm of orthopedic robotics. It is now my pleasure to turn the floor over to Dr. Launer to begin today's presentation.
Well, thank you, Laura. Welcome, everyone, and appreciate you spending part of your afternoon with me today, and wish you a enjoyable July 4th holiday weekend. My discussion today will focus on whether robotics make clinical sense, and then also to address whether, as we transition a greater percentage of our partial knee replacement cases into the surgery centers, whether it makes financial sense to use robotic technology in the outpatient surgical center setting. I will focus less on the technical aspects of the robotic devices than I will on more of a broad look at the robotic technology that's available today and how we're applying those in an outpatient surgery center. We'll have plenty of time after my presentation for questions and answers, and certainly hopefully at that point if anyone has questions about protocols that we use for outpatient surgical procedures, whether in the hospital setting or in the surgery center, I'd be happy to discuss that. So let me just give you a little background about my experiences. I first started to use robotic technology in 2008. Was one of the first surgeons in the U.S. to use robotic technology for unicompartmental knee replacement surgery. And over the course of several years, having gained a good amount of insight and experience with robotic technologies, we began work on what I consider the next generation of robotic technology, and one which I use today at two centers, one an inpatient hospital, the other an outpatient surgical center affiliated with a hospital and a health system. The procedures that I'm doing in the hospital, for the most part, are being done on an outpatient basis. And the reason we do those cases right now in the hospital is because the surgery center at the hospital cannot yet accommodate joint replacement surgery, but we'll transition those to a surgery center in a few years. So with that in mind, thanks again for coming out to hear the talk. See if I can scroll through. So by way of disclosure, I have several pertinent disclosures. One is that I'm a consultant and designing surgeon for Blue Belt Technologies, which manufactures a semi-autonomous robotic system that's currently in use in the United States and worldwide at the present time. I'm also a consultant and designing surgeon for Zimmer. Excuse the brief delays, but periodically I'll get a little thing that comes up on my computer and it keeps me from advancing the slides. So what are the conventional approaches to knee arthritis worldwide? I think that most of us feel most comfortable doing total knee replacements. And certainly if you look in the United States at what the majority of surgeons are doing when confronted with a patient who has surgical arthritis of the knee, the majority of surgeons are offering and performing total knee replacements. And certainly total knee replacements can work very well for the majority of patients. We expect clinical success in well over 90% of patients and durability well into the first and second decades postoperatively. The problem is, though, is that many patients will decline total knee replacement surgery. In fact, about 90% of surgical candidates who come in for discussion regarding their knee arthritis will decline surgery. Only about 10% of patients will choose to undergo total knee replacement surgery, and patients decline surgery for a variety of reasons. Certainly, many of our patients are fearful of the pain that has historically been associated with total knee replacement surgery. And nowadays, though, the good news is that we have much better strategies for managing surgical pain, whether we're talking about total knees, revision knees, or partial knees. Our pain management protocols and our rapid recovery algorithms are much better at accelerating the whole recovery process and reducing surgical pain. Our patients, though, are also fearful of being out of work. And if we consider that half of our patients in whom we operate nowadays are working age and need to get back to work sooner, there's a big concern that patients may be out of work for an extended period of time. That will often be a barrier to undergoing total knee replacement surgery. And then, of course, the things that always stand out in patients' minds are the horror stories that they may have heard through a friend of a friend of a friend. And those are the things that really concern patients. Certainly it concerns surgeons, too, when they see horrible outcomes. But it's a big barrier for many patients to finally make the decision to go ahead with surgery. And then ultimately, I think many patients and frankly even surgeons are poorly informed about some of the alternative treatment strategies for knee arthritis. Many surgeons even are not trained in partial knee replacements. Now we're in a different era of surgical education right now, and I think more of our residents and fellows are being exposed to partial knee replacements than was the case 20 years ago. So as time goes on, surgeons will begin to offer partial knee replacements at a greater clip compared to 5, 10, 15 years ago. Now, as good as total knee replacements have been, we know from several studies that unfortunately approximately 20% of patients are dissatisfied after a total knee. And they might be dissatisfied because the recovery was longer than they had expected or had hoped for. Maybe they have some activity limitations where they can't do certain activities that they had hoped to pursue after knee replacement surgery. And in many patients, expectations may be unmet. Part of the problem is that we as surgeons need to do a better job aligning the patient's expectations with the reality of total knees. But this reality of 20% dissatisfaction is certainly concerning when we look at our total knee replacement patients, despite what we may perceive as excellent functional and clinical outcomes. And we all know that many of our total knees don't feel normal. They feel a little bit mechanical. There's a little bit of residual pain in the soft tissues after total knee replacement surgery. And that's always a little bit frustrating. So issue one, and the good news, is that not all of our patients coming in for the surgical management of knee arthritis need total knee replacements. Many patients are suited to some alternative therapies. And if we look at patterns of arthritis that affect our patients who come in for knee replacement surgery, only about 6% of patients will have arthritis that affects all three compartments of the knee. The reality is that many of our patients will have arthritis that's more localized. And then depending on which study you review, somewhere between approximately 15% and close to 50% of patients will have arthritis in only one compartment of the knee. Certainly a larger percentage will have arthritis in two compartments of the knee, but only 6% of patients have arthritis in all three compartments. So there are a continuum of interventions that we can consider when evaluating our patients who come in for the surgical treatment of arthritis. Certainly we can do partial knee replacements, and we can do total knee replacements on the one extreme. We can do patellofemoral arthroplasties for patients who have arthritis that's localized to the patellofemoral compartment. We can do a medial or lateral knee arthroplasty, or we can combine the two, which does have some kinematic benefit, again, particularly in our younger patients, but even in our elderly patients. These more conservative treatment strategies can make a lot of sense. Now, certainly the choice of knee replacement surgery doesn't just depend on the pattern of arthritis, although that's certainly an important determinant. The patients in whom we would consider for partial knee replacement typically should have less deformity, so minimal varus or valgus deformity, and those parameters are all described well in the literature. They should have minimal to no flexion contractures. They should have good range of motion and excellent functional stability of the cruciate ligaments and the collateral ligaments. And typically, patients should be on the thinner side, although there's good data to support doing a unicompartmental knee arthroplasty in patients who are mildly to moderately obese. So there's a lot more that goes into the consideration for partial knees than just the pattern of arthritis. I think it's important that we as surgeons very carefully, critically evaluate each of those elements before deciding to pursue partial versus total knee arthroplasty. In my experience, 30% of patients who come to see me will receive partial knee replacements, and the other 70% get total knees. Some surgeons, either because of referral patterns or because of their strict selection criteria, may do 10% or less. And then there are some surgeons on the other extreme who might do as many as 50% partial knees. Ultimately, whatever it is, I think the surgeons need to feel comfortable in their selection criteria and with their surgical skill set to choose the right patients for the right procedure. Now, what are the advantages of partial knee arthroplasty? We know that patients will recover more quickly when we do a partial knee versus a total knee arthroplasty. There's less pain associated with the surgery. And once patients are fully recovered, there's less residual pain after a partial knee, particularly unicompartmental knee, compared to a total knee. There's less blood loss at the time of surgery with partial knee, less perioperative morbidity, a shorter hospitalization. In fact, now for many of us, 95% or more of our patients undergoing partial knee replacements are being done on an outpatient basis. These are more conservative, and by virtue of the fact that we can retain the cruciate ligaments and the other cartilage surfaces of the knee, knees tend to feel more normal, and our patients have typically greater satisfaction with the end product compared to our total knee replacement. And if we look at the costs of delivering care, we can deliver the partial knee replacements at a fraction of the cost compared to total knee replacements. And these are all important considerations. Now, patients will often ask, how long is it going to take for me to recover after partial knee replacement surgery? And really what the majority of patients are asking is, how long is this thing going to hurt me? And when we look at the pain scores after, we look at the pain scores after total knees and unicompartmental knee replacements. In general, the patients will have diminution of their pain that occurs about 2/3 faster than it does after total knee replacement. So we expect our patients to get off pain medicine much more quickly after unicompartmental replacement than after total knee replacement. And certainly we see that almost routinely. Now, what about the time to recovery and the time to return to functional activities? There have been a number of studies that have looked at this. And again, what we see is that after unicompartmental knee replacement, patients will recover about 2/3 faster compared to total knee replacement patients. And how about the extent of recovery? This has been looked at recently, and when unicompartmental knee arthroplasties were compared to total knee arthroplasties, patients were able to get back to full activities of daily living, and the knees felt more normal about twice as quickly as total knees when we look at unicompartmental knee arthroplasty. So this is a big deal, and what we're seeing then is quicker recovery and a more profound recovery after partials versus total knees. And ultimately, what about patient satisfaction? Because really, patient satisfaction is what determines success after knee replacement surgery. And unlike the total knees, where only approximately 80% of patients are satisfied, with partial knees, about 94% of patients are satisfied. And again, in this case, this is looking at unicompartmental knee arthroplasties. The patellofemorals are a whole different ballgame, but partial knees, at least as it relates to unicompartmental knee replacement surgery, will have a far greater incidence of satisfaction compared to total knees. Now, what about the safety of the two? If we go and we look at tens of thousands of patients using national registry data, so databases from Medicare and MarketScan. MarketScan looks at the data from patients who are 65 and younger. What we see is that the incidence of 30-day complications after partial knee replacement is 2 to 3 times less than the complications that we see after total knees. So the incidence of bleeding, incidence of myocardial infarction, infection, pulmonary emboli, rehospitalization, and death occurs at a much lower rate after unicompartmental knee replacement surgery, and at least also my own experience of over 300 patellofemoral arthroplasties, we're seeing similar numbers. So the surgeries are much safer when we do partials compared to total knee arthroplasty. Now, the other issue, though, and this is an important issue and one where robotics kind of comes into play, is the survivorship. So if we look at the durability of unicompartmental knee replacement surgery, the results can be remarkably good in terms of survivorship. In fact, just as good, if not better, than the 10 to 15-year survivorship that we see with total knee replacements. However, this is all data from highly skilled surgeons who do very high numbers of unicompartmental knee replacement surgery using good implants. Unfortunately, though, if you look at the masses and if you look at these U.S. databases that have tracked tens of thousands of patients, the failure rate of unicompartmental knee replacement surgery in the hands of the masses, so surgeons who typically do less than 10 or 20 unis a year, and most likely less than 5 or 10 unis a year. The failure rate is too high. So the failure rate at 5 to 10 years in partial knee replacements amongst low-volume surgeons who may have selected the wrong implant is far too high compared to total knee replacements, and certainly something that we have to consider if we're considering increasing our numbers of partial knee replacements. So the second issue that I think is very important is that we have to come up with ways to improve the outcomes and durability of partial knee replacements in these patients who are looking for some alternative to total knee replacement surgery. And there are certainly a variety of things that can impact the results of partial knee replacements. Clearly, we have to be selective in terms of who we do the surgery in. So make sure that the pattern of arthritis is appropriate, that there's minimal deformity, that the ligaments are functionally stable. Then we have to choose components of good design, good polyethylene quality. Some surgeons will feel comfortable doing the surgery Some patients will feel comfortable doing the surgery with a variety of different unis, and some will rely on established data to choose their implants. We also know that the accuracy of implantation, particularly fixed bearing, is a key driver of success in unicompartmental knee replacement surgery. My own personal bias is that even in mobile bearing unis, you still have to be accurate in how you position the components, and very importantly, you have to balance the soft tissues well. In surgery. So from bulky instrumentation to computer navigation, and now we're in this very interesting realm of robotic technology, and that's what we're going to discuss a little bit more today. The rationale of robotic surgery for partial knee replacement surgery is to simplify the procedure. Despite the great sophistication of robotic technology, it actually makes the procedure easier to do. We can minimize the amount of instrumentation, reduce the instrument trays, eliminate surgical steps, and the technique of doing the surgery has become far more predictable. When we look at the results, we've enhanced the accuracy of bone preparation and component alignment, and we're much better now at balancing the soft tissues and quantifying the balance in the soft tissues compared to when we use conventional techniques. And what we're finally starting to see now, compared to some of these national registries and international registries, is improved clinical results, at least as it pertains to the durability of the partial knee replacements. So what has the experience been with orthopedic robotics? We've seen initially back in 2007, 2008, a good deal of skepticism about the role of robotic technology, to now a much broader adoption of semi-autonomous robotic systems. There's been expanded indications, so while the initial application was for unicompartmental knee arthroplasty, now we can use robotic technology for patellofemoral and bicompartmental knee replacements. Soon we'll have application of robotics for femoral acetabular impingement. We're using it in total hips. We're going to see it at some point in the near future for total knees. There are robotic technologies available for spine spine surgery, and the indications will continue to grow and expand over the next 5, 10, and 15 years. We're seeing newer companies come into the market, and technologies continue to advance. The market penetration has been rather exciting, particularly for those of us who are early adopters and who often wondered why there was not a more broad endorsement of robotic technologies. Now, at least as of 2013, 15% of unicompartmental knee arthroplasties in the United States were being performed with robotic assistance. The numbers now in 2015 are probably closer to 20%, and these numbers will continue to grow. And certainly the expectation is that those numbers will grow over the next 5 and 10 years. Recently, there was a poll taken amongst orthopedic surgeons. Most of the surgeons who were queried are non-robotic users at the current time. Some are on the verge of using robotics. Some already use robotics. But the majority of the physicians queried were non-users. And what the finding was is the expectation is that over the next 5 years, approximately 30% of partial knee arthroplasties in the United States are going to be performed with robotic technology. And the expectation is that by 10 years from now, 37 or almost 40% of partial knees will be performed with robotic technologies. There's a similar expectation that as robotics evolve, over the next 2 years, maybe 10% of total knees will be performed with robotic technology, and perhaps nearly a quarter of total knee replacements in 10 years from now will be performed with robotic technology. And I fully expect, knowing the potential of robotic technologies, not just in improving component alignment, but perhaps even more importantly, in balancing the soft tissues, that there may be a substantial role for robotics for total knee replacements in the next 10 years. So currently there are 2 semi-autonomous robotic systems available in the United States for partial knee arthroplasties, both unicompartmental and patellofemoral arthroplasties. System, which was first approved for use by the FDA in 2005, and then after some modifications of the system was reapproved with the modifications in 2008. That system is still available today. It's image-based in that it requires a preoperative CAT scan. The second system currently available is the Navio system, FDA approved in 2012. This system is image-free. It does not require a preoperative CAT scan. And what my observation has been with regards to robotics and orthopedics is that this is really a study in the patterns that define technological progress, development, and innovation in general, not just in healthcare, but across all sectors of society. And that's marked by declining capital costs, maintenance costs, smaller space requirements. And as these things occur, there's broadening access and greater utilization of those technologies. And I'd refer you to this wonderful book by Brynjolfsson and McAfee called The Second Machine Age. It's very enlightening. Addresses a little bit about healthcare technologies, but it deals mostly with technologies in general, and I found it to be a very interesting read. Well, the observations that many of us have had with robotics, including the first generation system, is that they dramatically improve the precision of the surgery in terms of component alignment, conservative bone resection, and functional outcomes. So what we've seen with nearly 1,000 robotic cases is that the polyethylene thicknesses are far far smaller than if we look at tens of thousands of conventionally performed unicompartmental knee arthroplasties. That's a big deal if we consider the complexity of revision if revisions to total knees are necessary down the road. We've also seen significant improvement in component alignment. But the downside, at least of the first generation robotic system, was that there was a very high capital expense associated with that technology, and that was a really significant barrier to broader adoption of the system. The other barrier to adoption is that it required a preoperative CAT scan. And unfortunately, over the last several years, the insurers have really balked on pre-authorizing preoperative imaging studies. So whether it's preoperative CAT scan or MRI for custom manufacturing of cutting guides, or in this case, for preoperative planning for robotic surgery, numbers of denials were growing. The amount of effort that the office staff had to put into getting approval for these scans was rather extraordinary. And unfortunately, in this day and age, where patients have high copays and high deductible plans, patients were being stuck with a large price tag, or the hospitals were eating the cost of the CAT scans if the insurers chose not to reimburse for these studies. That was a big deal. And in this day of bundled payments, no one's going to want to split the extra cost of a preoperative CAT scan or MRI. So those are big considerations, and in my experience were rather significant impediments to broader adoption of the first generation robotic technology. There was a certain time and inconvenience of having to get a preoperative CAT scan as well, particularly for patients who often came from quite far away. For those patients, it was a little bit onerous to have to get a preoperative CAT scan. And then finally, what we've seen and published on is that there is a fairly substantial radiation exposure associated with these preoperative CT scans using current protocols. And that's becoming increasingly more concerning in healthcare in general. With the second generation robotic technology, we've been able to eliminate the preoperative CAT scan. The current system is a handheld robotic instrument. All of the registration, all of the mapping, the planning, the sizing, the virtual ligament balancing, this is all done intraoperatively, and it's all done before starting bone preparation. With this particular system, the protection against inadvertent bone resection comes by the system modulating the speed of the burr or the exposure of the burr beyond the protective sheath. And we've found tremendous success and accuracy with both of these systems, the first generation and the second generation system. The second generation system is a bit more cost favorable, and I'll discuss that a little bit further. And the good news is that as we transition more and more of our partial knee replacements in outpatient setting, we have to look at technologies that can be useful and cost-effective in an ambulatory surgery center. Currently, about 1/3 of the second generation robotic systems are being installed in and utilized in freestanding surgery centers. The remainder are being placed in inpatient hospitals with the expectation that as surgeons become more comfortable in the performance of outpatient surgeries, those cases might be able to be transitioned into a surgery center. In this slide, I was showing a little bit of the bone preparation and the technique of bone preparation that we use with the current robotic technology. So in this case, using a handheld motorized burr, we can very carefully sculpt away the articular surface. And in the upper left corner, you can see virtually what we're doing in real time. And in the larger video screen, you can see at the surgical field how the burr is being moved, how the burr is being used to very carefully remove the arthritic surface. And what you can see here is that when we're in plane, the motorized burr is extended outside of the guard, but when we're out of plane, the burr retracts back within the protective sheath. And with that, we can get very smooth condylar surfaces. So here we see, after bone resection, despite using a 6-millimeter burr, how smooth the surfaces are on the medial femoral condyle and medial tibial plateau. And we've seen this actually with both systems that are available, which really highlights the effectiveness of these semi-autonomous robotic tools. The important thing always is the data. And we've now been using robotic technology for long enough that there have been a number of publications looking at component alignment with and without robotic technologies. And in several studies that have been published, it's been remarkable how much less error there is in component positioning when looking at all the important parameters compared to when we do unis using conventional technologies. So if we look at component flexion extension, varus valgus, rotation, translation, all of those, there is a far greater amount of accuracy in bone preparation and component positioning compared to those knees that are done with manual techniques, and far less variability. So the target area is tighter with less range in the order of 2.5 times when we look at robotic techniques versus conventional techniques. And now we're finally starting to see some payoff. So when we look at over 800 cases with a mean follow-up of about 4.5 years, the failure rate for mechanical reasons is about 0.5%. Well, that's a pretty low mechanical failure rate, and I think it's directly related to the fact that we can align the components so well and balance the soft tissues so precisely with robotic technologies. So the third issue is the value paradigm in replacement surgery and how robotics may fit into that. So let's talk a little bit about the value paradigm. If we look at the healthcare expenditures nowadays, all of us are well aware that currently 17% or more of our gross domestic product is being spent on healthcare. And those numbers are expected to grow and grow and grow. And that's why there's such great emphasis now in strategies to contain costs, access, and contribute to a more responsible way of delivering healthcare. It's expected that by year, so if we consider the growing burden and volume of total knee and hips expected over the next 15 years, we can only imagine that the cost of managing musculoskeletal disease is just going to keep growing and growing and growing and growing. So we as physicians need to try to figure out how to optimize value. Payers are encouraging value-driven choices. They're driving patients towards surgeons and hospitals who can deliver a higher value, lower cost product. And there's incentives now for providing a quality product over a quantity product. There are penalties for readmissions. And ultimately, we as physicians need to figure out how to optimize care. So what is value in joint replacement surgery? Is it patient satisfaction? Is it improved functional outcomes? Is it enhancing the implant durability? Is it allowing our patients to recover more quickly so they can get back to work more quickly? Is it optimizing patients so that we can minimize the risk of postoperative complications? Is it avoiding short-term costs and minimizing long-term costs by reducing the need for revisions? Well, I think it's a little bit of all of these. Certainly, if you ask our patients, I think they would agree. But if we look at the insight from Michael Porter, who's considered one of the gurus in the value initiative in healthcare currently, it's in its truest form, it's delivering care and improving healthcare outcomes at a low dollar value. And I think ultimately we have to continue to look at ways to optimize quality by minimizing costs. So how do we get better value? Well, we can minimize costs through the entire episode of care by improving our protocols and algorithms. We can optimize our patients medically and reduce some of the perioperative medical events that occur in poorly managed patients and minimize their complications. We can educate our patients in terms of their expectations and creating protocols to streamline the postoperative care. And finally, we need to reevaluate the cost of care at various hospitals so we can drive cases out of the more expensive tiered hospitals towards the less expensive tiered hospitals, so moving patients from academic centers to academically affiliated community hospitals, for instance, is one strategy being worked on by a variety of centers. We can minimize the use of inpatient facilities in the postoperative period, so we can reduce the routine use of inpatient rehab, for instance. And then finally, we can transition select cases from the hospitals to surgery centers, and perhaps by better education programs and by introducing technologies that optimize outcomes, we can shift cases from total knees to partial knees in appropriately selected situations. Now, Medicare is really pushing the issue of doing partial knees on an outpatient basis. And to a certain extent, they started doing this before there was even much data. So what we did is we looked at issue 4, first and foremost, to determine whether outpatient partial knee replacement surgery is safe, either in the hospital setting or the surgery center setting. And then we wanted to look at whether robotic technology supports this new value paradigm in healthcare and determine whether robotics are safe and cost-effective in the ASC. So first, we wanted to look at safety, and we looked at 200 consecutive selected patients to be done on an outpatient basis. So these are patients who are relatively healthy. 50% of these were done in the surgery center. The other 50% were done at the hospital. There's a whole range of ages. You can see up to 82. All of these patients were discharged home. We had one patient in this cohort who returned to the emergency department on day 1 for some intravenous fluids. No readmissions amongst this group of patients. So you can see that it can be done safely in well-selected patients. Now, what about the cost of care? So when we looked at the cost of delivering care, in this case, the care of performing a unicompartmental knee arthroplasty, in 3 different settings, what we found was fairly dramatic. So we had 50 patients in 3 groups. One group was patients who had unicompartmental knee replacement surgery at the hospital on an inpatient basis. The other group had outpatient unicompartmental knee arthroplasty at the hospital. And the third group had outpatient unicompartmental knee arthroplasty at the surgery center. And what we found is that with each change in location, approximately a $3,000 cost savings. And if you look at the mean difference between delivering a unicompartmental knee arthroplasty at the hospital on an inpatient basis versus delivering a unicompartmental knee arthroplasty at a surgery center, obviously on an outpatient basis, there was about a $7,000 cost savings between those extremes. And I think we've reduced those numbers even further with a more careful assessment of how we deliver care in the surgery center. So these are numbers, and these are the costs of care, not the charges, which, as you know, are a much inflated number. So these are the costs of care, and a very important statistic that we've looked at. So what about the economics of robotic technologies? I mentioned how technology in general, with each iteration, each generational change, there's going to be a reduction in the costs of that technology, a reduction in the cost of servicing that technology, and in the different features that are important for maintaining those technologies, service charges, disposables, there typically is a reduction in cost as well. And that's certainly what we've seen as we've progressed from the first generation technology to the second generation technology. Lower cost of the system, lower support costs, lower disposable costs, elimination of the preoperative CAT scan, which has a cost, quicker setup times, which has a significant cost as well, and greater portability because of the smaller footprint of the system. We're able to move the system between rooms much more easily, and there are a number of healthcare centers throughout the country where the second generation robotic technology is being moved from hospital to hospital, depending on who's operating at that particular hospital. And then ultimately, if you look at an economic analysis, the return on investment can be significantly greater or quicker with the second generation technologies. And I won't belabor the costs of everything, but we can break even and realize our return on investment in a fraction of the time with newer generation technologies, given the lower costs. But I think ultimately each hospital or each center has to do their own analysis to figure out whether the technologies can work for them before determining whether the advanced technologies make sense in their particular setting. So in conclusion, and hopefully the phone line doesn't cut out before I finish the next 3 slides, partial knee arthroplasty is a conservative alternative to total knees. It allows our patients to recover more quickly. They're more likely to get back to sport and work more quickly. These knees tend to feel more normal. There's less surgical risk, and we're seeing greater patient satisfaction after unicompartmental knee arthroplasty compared to total knees. Robotically assisted surgery significantly improves the precision of bone preparation compared to conventional techniques. It optimizes ligament balancing and optimizes positioning of the components. And what we're starting to see now is improved durability with this advanced technology, again, by the virtue of the fact that we're positioning the components better and balancing the soft tissues better. And finally, partial knee replacements can be delivered safely in an outpatient surgery center, and the newer generation robotic technologies are proving cost favorable for the outpatient surgery center environment, and they clearly support the value paradigm. I mentioned earlier that currently about 1/3 of robotic technologies of the second generation technologies are being used in the outpatient surgery center setting. And I think those numbers are going to continue to increase. Certainly that's something the hospitals are considering as well as they consider the importance of the whole value paradigm. Well, at this point, hopefully I haven't lost you all, and we can take questions if there's time for questions. Laura?
Absolutely. Thank you very much, Dr. Lahner, for your informative presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Dr. Lahner will attempt to answer as many questions as he can during the time we have, and will follow up on questions we do not have the opportunity to address. And the first question we have here is, what is impending the transition of joint surgery, what is impeding the transition of joint surgery in the ASC?
Well, I think there are a few barriers to broader endorsement of outpatient surgery. And until those barriers are really broken down, there are going to be barriers to adoption in the ASC setting. First and foremost, and this was certainly my case too, the surgeons have to feel comfortable that if we send our patients home on the day of surgery, that it's going to be safe and that they won't run into medical problems, arrhythmias, bleeding issues, dehydration when they're at home. And now there's more and more data regarding safe protocols for outpatient partial and total knee replacement and hip replacement surgery, and more data that reviews the outcomes. So as surgeons start to feel more comfortable with that, then there's going to be a sense that once the protocols are established at the hospital setting for outpatient surgery, we can move to the ASC. The ASC, in my experience, the administration of these ASCs are typically rather enthusiastic, as are the staff, for doing partial and total knees. But surgeons and patients have to feel comfortable with transitioning joint replacements first to an outpatient setting and then to the ASC.
Absolutely. And the next question I have is, what is your pain management protocols for your uni knees and when you perform them in an ASC setting?
So we do a preemptive analgesia protocol that includes a COX-2 inhibitor for 2 days prior to surgery with oxycodone or OxyContin the morning of surgery. And then in the postoperative period, patients are sent home with Percocet and some medicine for nausea. Now, the other issue that I think is very helpful is the choice of anesthesia. We typically use spinal anesthesia and do so for probably 99% of our patients. We use a low-dose bupivacaine. Some anesthesiologists also use a low-dose fentanyl because they can minimize the use of bupivacaine, which many of the anesthesiologists feel may reduce the risk of urinary retention. And then finally, we inject the capsule of the joint with ropivacaine, and that or bupivacaine can be a very useful method of preemptive analgesia, and seems to work very effectively. We also use COX-2 oral medicines, Celebrex, in the postoperative period to supplement the Percocet. And between all of these things, we've been very pleased with the reduced pain that we see in our partial knees on an outpatient basis.
Absolutely. And finally, the last question I have is, what items are included in the cost figures you share for the ASC? The implant, direct and indirect costs?
These are the direct costs. So the things that you billed for, we did not look at surgical time. These were just direct costs. So disposables, implants, the various things that go into the operating room, anesthesia. We did not look at the indirect costs.
Absolutely. Well, I want to thank Dr. Lahner again for his excellent presentation and thank all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.